patients with those really large symptomatic goiters, especially the ones who are poor surgical candidates, our options have always felt, well, a bit limited. But a brand new study from Gadd and his colleagues in the Journal of the Endocrine Society is proposing a really fascinating solution: pressure-enabled thyroid embolization. So let's break down their findings together. So here's how we're going to tackle this. First, we'll set the stage with the clinical challenge we all face. Then, we'll dive into the novel technique they developed. After that, we'll get into the weeds of the study's design and, of course, the results. And finally, we'll wrap up by thinking about what this could all mean for our own clinical practice. All right, so let's start by just framing the problem. We've all got these patients, right? The ones with large, benign goiters. And when they become symptomatic, causing real trouble breathing or swallowing, we're faced with a serious clinical challenge. Finding the right intervention isn't always straightforward. And this image, wow, this just illustrates the severity of the problem perfectly. What you're looking at here is a massive goiter causing more than 90% narrowing of the trachea. This is exactly what leads to those awful compressive symptoms we see in the clinic: the dyspnea, the dysphagia, sometimes even stridor. It's a huge quality of life issue and a clear, urgent call for an effective fix. Our current toolkit really has its trade-offs. On one hand, you've got thyroidectomy. It's the standard of care, sure, but it's not without some serious risks. Think nerve palsy and, of course, guaranteed lifelong hormone replacement. Then on the other hand, you have minimally invasive options like ablation, but they're often just not effective for the really big goiters that cause these problems. We're talking volumes way over 20 milliliters. And traditional thyroid artery embolization, TAE, has always been dogged by this risk of non-target embolization, especially the scary stuff like cerebral vascular events. It leaves this huge clinical gap. So this is exactly where the innovation in the Gadd study comes into play. They've come up with a new take on embolization that's specifically designed to get around these safety concerns. To really get what they've done, we have to appreciate the anatomy here. The thyroid has this dual blood supply: the superior thyroid artery branching off the external carotid and the inferior thyroid artery coming up from the subclavian. The big risk with traditional TAE has always been trying to catheterize that superior artery so close to the carotid circulation. Any reflux of those embolic particles could be absolutely catastrophic. So the key, the real magic, is this piece of technology: a pressure-enabled drug delivery catheter, or PEDD. Now, what's so cool about this is its mechanism. The catheter has this special one-way microvalve. When the particles are injected, this valve creates a forward pressure gradient that's so strong it actually pushes the embolic spheres through the thyroid's own internal collateral vessels. But, and this is the crucial part, it prevents any backward flow, no reflux. And here's exactly how it's applied. Look where that catheter is. It's positioned only in the inferior thyroid artery, which comes off the subclavian, way, way away from the vertebral and carotid arteries. They don't even have to go near the carotid circulation. That right there is the fundamental safety advantage. Okay, so this is the money shot right here. Just look at this angiogram. The injection is happening way down in the inferior artery, but that pressure gradient is so effective it causes flow to reverse, pushing contrast and the embolic particles all the way up, filling the distal superior thyroid artery. Can you believe that? This lets them completely embolize an entire thyroid lobe from one single, much safer access point. It's a truly elegant solution to a very old problem. The technique itself is just fascinating, right? But now, let's actually turn to the study itself and take a look at how Gadd and his colleagues actually evaluated its clinical performance. So who were these patients? Well, this was a retrospective review of 22 patients, mean age around 59, and mostly female, which is pretty much what you'd expect. Half of them had multinodular goiters. That's really our key population for these compressive symptoms. And a pretty good chunk also had toxic nodules or were hyperthyroid. The study itself took place over about a year. They used these 100 to 300 micron microspheres. Now that size is really important. It's chosen to be big enough to block the precapillary arterioles, but still small enough to get really deep parenchymal penetration, which is what you want for a thorough devascularization. Access was almost always transradial, in 82% of cases, and they managed to get 6-month imaging follow-up for most of the group. All right, let's get to the good stuff. The data. What did they actually find? Was it effective, and was it safe? And here is the headline number: a mean gland volume reduction of 73% at 6 months. Just let that sink in for a second. That is not only statistically significant, it's a massive degree of shrinkage. Think about that patient you saw last week, the one with the goiter pushing on their trachea, who really didn't want surgery. A 73% reduction? That could be a total game changer for them. And if you're wondering what 73% actually looks like, well, here you go. The before image on the left is that same patient we saw earlier, the one with the severe tracheal compression, and on the right, after the procedure, you see this dramatic reduction in the goiter, and, most importantly, the trachea has totally re-expanded. That is a powerful, powerful visual of the clinical impact we're talking about. And it wasn't just about size reduction. There were also significant hormonal benefits. Of the 7 patients who came in with non-Graves hyperthyroidism, 5 of them, that's 71%, actually converted to a euthyroid state. So that just adds another whole layer of clinical utility to this procedure. Okay, but what about safety? That was the primary worry with the old TAE method. Well, the results here are incredibly encouraging. The vast majority of adverse events were grade 1. We're talking mild pain or discomfort that was gone within 2 weeks. And crucially, there were 0 major complications and, most importantly, absolutely no neurovascular or cerebrovascular events reported. None. So what we have here is really impressive efficacy and a fantastic safety profile. So what does this all mean for us, and where do we go from here? Well, the authors put their results into context by comparing them to historical data on traditional TAE, which usually gets around a 56% volume reduction. Their 73% reduction suggests this new pressure-enabled technique might not just be safer, but actually more effective. And that's possibly because they can use smaller particles and get a deeper, more complete embolization. And they also explored this really neat novel application, using the technique as a neoadjuvant therapy before surgery. On the left, you see a super hypervascular nodule. Then, on the right, that's the view during surgery after embolization, a pale, devascularized lobe. This could be a huge deal for reducing intraoperative bleeding and just making surgery safer for those really large, complex goiters. Of course, this wouldn't be a proper journal club discussion if we didn't acknowledge the limitations. And there are some. This was a small, retrospective study from just one center, and it was performed by one very experienced operator. So generalizability is a question, and we're definitely going to need longer-term follow-up data to see how durable these results are. And the good news on that front is that work is already underway. The authors mentioned that a multi-institutional registry, it's called PROTECT, has already been launched, and this is going to be absolutely crucial for validating these very, very promising initial findings in a much larger, more diverse population and with different operators. So we're left with a really compelling question. Based on this early evidence, this enhanced safety and potentially superior efficacy, could this pressure-enabled technique become a frontline, minimally invasive treatment for our patients with large, symptomatic goiters, especially those who are poor surgical candidates or just want to avoid surgery? It is for sure a development worth watching very, very closely.